Okay, here we go. This slippery little boy is one of our penrose drains. This is what we use during our liposuction surgery at the very end for people that have more severe lipedema. So we got this long drain. It's a 1/4 inch penrose drain. It's 18 inches long. The reason that I like this is, as you can see, it's flat and it's super floppy. Some of the drains that we use in plastic surgery are circular and they're kind of firm and they've got the grenade or the ball on the end of them. I hate those drains because they're really uncomfortable. They press into the skin under compression, or you gotta cut a hole in the compression and tunnel it through. It's a massive pain in the butt. Whereas with this is like super floppy, it's really comfortable. And the thing about this is it's open and it's continuously draining. And the reason I like that rather than the bulb or the grenade is that what happens with the grenade is it tends to fill up and then it's full and it doesn't really drain anymore. Or, you know, like the bulb snaps off and it leaks all over you and then you're like a mess. So like, I think the most effective drain is one that is draining, right? It should be continuously draining. So what these do is we'll cut these up often into 4, 5, 6 segments per drain, and I'll tunnel them into the incisions in areas that are high risk for seromas. We'll talk about that later. But by doing that, you keep the incision from snapping closed too prematurely. So when you keep the incision open and you've got this slippery silicone drain, fluid is going to continuously leak out. And that's good. We want the fluid to come out afterwards. Your body's going to swell, you're going to have a lot of trauma and inflammation under the skin, and we want a lot of that to come out so that the skin can shrink down and it can mold to its new environment. So, you know, ultimately, if I have someone that's like stage 1, they typically don't need a drain because the liposuction doesn't have to be that aggressive. But once you start getting into like late stage 2, early stage 3, you're probably going to need a drain in some areas. So the areas that I find that are most troublesome for seromas are on the lower legs, and they're usually down by the ankle or up by the knee, and I'll usually put drains in there. Or on the thighs, I typically see seromas on the outer thigh, right around the knee, or up towards the hip. So I'll typically put the drains in those areas to keep those areas continuously draining fluid so that they can kind of shrink down and heal more uniformly. The problem with a seroma is that once it develops, you're kind of stuck with it for a while. So imagine that this is your muscle, this is your skin, and we've got some space in between that's filled with fat, and you suction out all that fat. So you want the space to collapse down and nothing to be there. But what's going to happen is before any scar tissue or any connections are made, that space is going to fill with fluid and get swollen. What we want is the drain in that space to let it continuously drain, and then that can stay down. If you get a seroma, what happens is you've formed a ball of fluid or a little pocket of fluid, and then you stick a needle in it and you drain it and it closes down, and then it can fill up again and then it can close down. So you want something that continuously drains so that the ball of fluid can't form, so that the skin stays continuously adherent down to the muscle so that space heals uniformly. So I think the best thing about, the best way to prevent seromas is to be proactive about it. I don't use drains on everyone, but I think after you've seen enough seromas and you've drained enough and you know how uncomfortable they can be, it's better sometimes to even just put a drain in for a couple days, just by getting that immature connection between the skin and the underlying connective tissue and muscle. That might be enough to prevent that area from filling with fluid, and you prevent a seroma, which makes a very happy patient. So with the drains, we like to secure them with a suture to the level of the skin. And that suture can pull and tug. It can be a little bit uncomfortable, but usually we take out the drains between usually 3 and 5 days after surgery. That's usually long enough to allow things to sufficiently drain. But then about that time, the discomfort of the liposuction starts wearing off, and the drain itself actually becomes the most problematic area. We want to get the maximum amount of drainage, but the minimum amount of patient discomfort. So you got to find that sweet spot in between. Also, when I've left these in for like 7 to 10 days, sometimes they start getting a little bit red around the incisions and patients get a little superficial infection and need antibiotics. So I think that drains do have risks. They're pretty minimal. When they do cause a problem, it's pretty easy to treat without going to the hospital. We can just do oral antibiotics and treat things here in the office. But I think overall, these can actually provide a lot of comfort benefit by getting rid of the swelling. because as patients swell, they get more uncomfortable, things get a lot more tight, makes it harder to move around. So by using drains in patients that need it, you can actually alleviate a lot of that discomfort before it ever happens because they never get quite as swollen. What do you all think? Some people think of them like an insurance and they'd rather have them to try and prevent problems. Some people don't like gross stuff. They don't want to drain as much as they have to, and they don't want some things sticking out of their skin. So it can be a really polarizing topic, but I think it's an important discussion between the patient and their doctor, and I would encourage you to ask your lipedema surgeon if they'll be putting drains in for your procedure. Did you have them in your liposuction surgery? Do you think they're gross? They are kind of gross.